Greetings from Indian Journal of Anaesthesia. I, Dr. Khushbu Pandit, will be presenting an original article from August issue of Indian Journal of Anaesthesia. Comparison of ultrasound-guided sacral erector spinae plane block and caudal epidural block for analgesia in pediatric patients undergoing hypospadias repair. A double-blinded, randomized controlled trial. Caudal block is most commonly used block for postoperative analgesia in children undergoing hypospadias repair. Erector spinae plane block, that is ESPB, promises to provide visceral and somatic analgesia and has been used at thoracic, lumbar, and sacral levels. ESPB at sacral level can potentially block pudendal nerve and may prove a better alternative to caudal block for hypospadias repair. We hypothesized that ultrasonography guided sacral plexus block, that is ESPB, may be more effective regarding the time to first rescue analgesia in pediatric patients undergoing surgery for hypospadias repair. The primary objective was time to first rescue analgesia in children undergoing hypospadias repair with ultrasound-guided sacral ESPB or caudal epidural block. The secondary objectives were to compare intraoperative hemodynamic parameters such as heart rate, systolic and diastolic blood pressure, fentanyl consumption, postoperative phase, leg activity, cry controllability, that is FLAC scores, and analgesic consumptions at 24 hours. The study was approved from the Institutional Ethics Committee and registered under CTRI. It was a randomized and double-blinded controlled trial where 50 pediatric male patients aged 2 to 7 years with American Society of Anesthesiologists physical status 1 to 2 scheduled to undergo elective surgeries for hypospadias repair under general anesthesia were included. Exclusion criteria were a history of developmental delay, allergic reactions to local anesthetics, infection at puncture site, or patient refusal or parental refusal. The group 1 included 25 patients where ultrasound-guided ESPB with 1 ml per kg of 0.25% bupivacaine was given, and group 2 had 25 patients where ultrasound-guided caudal epidural block with 0.5 ml per kg of 0.25% bupivacaine was given. Regarding the sample size, as per the pilot study of 10 cases, the time to first rescue analgesia was 12.4 hours in sacral erector spinae plane block group and 6.61 hours in caudal block group, with a mean difference of 5.79 hours for sample size calculation and with a 95% confidence interval, 80% power, and alpha value of 0.05, the sample size came out to be 20 in each group. In order to balance for dropouts, the sample size was estimated as 25 in each group. Statistical analysis was done using SPSS 25. Regarding the results, the primary outcome was the mean time to first rescue analgesia, and it was significantly longer in group 1, that is sacral erector spinae plane block group. Regarding the secondary outcomes, the mean FLAC score for group 1 was significantly less. The FLAC scores were significantly higher postoperatively at 8, 10, and 12 hours in group 2, that is the caudal block group. And the mean postoperative analgesic consumption, which was of paracetamol, it was significantly less in group 1, that is sacral EPSP group. So these are the results where we can see that the FLAC scores was significantly lesser in group 1. The time to first rescue analgesia was significantly higher in group 1. The mean postoperative analgesic consumption, that is of paracetamol, was significantly lesser in group 1, and the number of doses for rescue analgesia were also significantly lesser in group 1. Therefore, the sacral erector spinae plane block is an interfacial plane block which provides somatic and visceral analgesia, blocking spinal nerves, dorsal and ventral rami. The erector spinae plane block at the sacral level can potentially block pudendal nerve. Bilateral effect can be produced with a single injection using midline approach. The strength of the study is non-inferiority of sacral ESPB as compared to caudal block, including various advantages of sacral ESPB. It is easy to perform under ultrasound guidance because it is applied relatively superficially and the injection site is not close to major vascular and neural structures. As a limitation, the study was a single center study, had a relatively small sample size, and it lacked long-term follow-up to assess outcomes beyond 24 hours post-operatively. Therefore, as a conclusion, ultrasound-guided sacral erector spinae plane block using the midline approach significantly prolongs the duration of post-operative analgesia when compared to ultrasound-guided caudal block in children undergoing hypospadias repair.